All right, good afternoon again, everybody. My name is Angad Buttar, and I'm Assistant Director for State Engagement at Shatterproof. Thank you for joining us today on our third webinar on our Continuous Quality Learning Improvement Learning Series. This is increasing the use of the ASAM dimensions of care in your facility. I have about 1:31 here on the East Coast, so we'll go ahead and get started as we want to be respectful of everybody's time. So what we'll go ahead and do today is walk everybody through a few slides. We'll introduce our esteemed speakers that will go through a small presentation, and then we'll get to some questions and answers at the end of the presentation as well. So if we can go ahead and get started here and get into the next slide. So our session agenda for today, we'll be talking about Atlas data that is supporting this core in central area. And as I mentioned, we'll be introducing our featured speakers, Dr. Thomas Britton and Mr. Jim Scarpace. And we're looking forward to a robust question and answer part of the session as well. And then we'll leave with some final thoughts and upcoming events as well. Next slide, please. So I think a lot of us have seen this slide before, but this is Shatterproof working to sort of standardize the quality expectations through the national principles of care that are listed here. These principles, which we have reviewed in previous sessions and we'll focus on today in more detail, were identified by a task force that were composed of subject matter experts, clinicians, and policymakers, and based on research derived from the Surgeon General's landmark report back in 2016. They're shown to improve healthcare outcomes across all levels of care for addiction and across patient populations. And today we'll be focusing on the second principle and the fourth principle. Next slide, please. So here we have a quick overview of the ASAM dimensions. Don't want to spend too much time here, but we did want to sort of introduce these dimensions just sort of so everybody could level set for today. And what we'll go ahead and do next is go to the next slide, and I'll turn it over to my colleague, Carolyn Davidson. Carolyn.
Thank you very much, Angad, and thank you all who have joined us. We're already at 130 participants, so we're very excited. So we wanted to give you a little bit of a sense of what we're seeing in the Atlas data that led us to really think that this would be a useful webinar. So as you'll remember, the Atlas data and the way it's organized in the public-facing website and also the password-protected portals is by the Shatterproof National Principles of Care, as Angad said. So we'll start with personalized evaluation and treatment plan. And so what we see here from the Atlas data is that 81% of facilities that submitted data across our 6 states assess patients on all 6 dimensions of care on intake. And 19% of facilities across all the 6 states assess fewer than 6 of those dimensions at intake. And when we look at which dimensions are being assessed, I'm going to move my screen a little bit right here, we notice that emotional, behavioral, or cognitive conditions and complications are the most frequently assessed, as well as relapse, whereas readiness to change is the least frequently assessed, indicating areas for potential improvement. But we're definitely excited by the numbers that we're already seeing. Now, in addition, as Angad mentioned, we're also looking at long-term treatment and follow-up because we know that addiction isn't a single kind of one-stop shop where you get one medication or you get one therapy visit and then you're done. So we wanted to understand to what extent are facilities assessing the ASAM dimensions in their long-term treatment planning. And here we found that the utilization of ASAM dimensions varies. It was fairly similar in terms of the number of facilities that are assessing on the ASAM dimensions in terms of monitoring. But what we found in terms of which dimensions are being assessed versus not, in this case, it's slightly different, that you'll see that emotional, behavioral, cognitive complications is still the top, but in this case, that acute intoxication or withdrawal potential is the least frequently assessed. And remember that a lot of this information is available in your professional portal. And so if you want to know, for instance, on a state level, how many facilities are assessing on all 6 dimensions, if you go into your facility profile, you'll be able to see that state level average. And with that, I will turn it over to my colleague Leah to do introductions.
Hello, everyone. So it is my pleasure today to introduce our speakers. Thank you very much, Dr. Britton and Dr. Scarpace, for joining us today. So Dr. Thomas Britton is the president and CEO of the Gateway Foundation Alcohol and Drug Treatment Center. Dr. Britton's involvement in the behavioral health field spans more than 30 years, and his extensive work history provides a rich background from which he leads the Gateway Foundation. Throughout his professional career, Dr. Britton has held the belief that all people hold the innate potential to improve their life and the lives of those around them. Dr. Britton is committed to lifelong learning, completing a doctorate in public health at the Gillings School of Global Health, a master's degree in addiction treatment, and a master's in marriage and family therapy. Currently, Dr. Britton is the president and CEO of the nation's largest nonprofit treatment provider, specializing in substance use disorder treatment. Dr. Britton has taught and lectured throughout the country. He's considered an expert on the intersection of addiction and the larger context of public health and policy. Personally, Dr. Britton has used his history of addiction and recovery to guide organizations and community to a place of compassionate but science-driven practice. Jim Scarpace is the executive director at Gateway Foundation. Mr. Scarpace has over 28 years of experience in mental health, substance use disorder, and the criminal justice field. He has a master's degree in clinical psychology and has been licensed clinical professional counselor for the last 20 years. He currently is assistant professor at the Chicago School of Professional Psychology and has taught graduate classes in clinical psychology for the last 17 years. His previous roles included being a supervisor for the Department of Probation and Court Services in DuPage County, where he assisted in developing a mental health program for high-risk youth, as well as supervised therapists and probation officers in the forensic setting who worked with juvenile offenders with mental health and substance use issues. In addition, Mr. Scarpace has also worked with chronically mentally ill adults in a hospital setting, focusing on treatment planning, assessment, and family counseling, preparing for discharge, as well as for several years in the community as a therapist with adolescents who have severe mental health disorders. Mr. Scarpace also coordinated a residential facility for high-risk children and adolescents involved with the Department of Children and Family Services. His areas of expertise include addiction, trauma, group therapy, crisis intervention, family therapy, and advocacy. Without further ado, it's our pleasure to turn you over to Dr. Britton and Mr. Scarpace. Gentlemen.
All right, let me share my screen real quick. All right, good afternoon. My name is Tom Britton. I am the hang on one sec. Sorry, let me turn this thing on, make sure we're looking good. Okay, there we go. So I'm very excited to be here. And thank you for the introduction. Thank you so much to Shatterproof for the work you're doing and for thinking of us as you thought about this presentation. What the background of myself and Jim didn't really communicate as well is really our passion for working in the field, understanding the field, and modifying our organizations to better serve the people that we support. And so today, you can't spend an hour and 15 minutes and become, an expert in using the ASAM placement criteria. What we hope to do in this is really give you some thought-provoking material to really think about how do you work as a clinician if you're a clinician, and how do you support your agency to be prepared to really integrate the principles of the ASAM placement criteria, of the levels of care into the work that you do. So just to first give you a very high level about my organization, and we'll go a little deeper into this. Gateway currently serves almost 9,000 people a day. We're in 9 states, over 80 locations. Jim, that's my partner in this presentation today. You can see him in the Aurora bullet up there. But we have comprehensive treatment at every level of care outside of 4.0 of hospital-based care. So everything from really kind of early intervention through detox level services. One of the things that we have been excited about is to really develop programming that is specialized to specific populations, because what we have found using Out in Recovery, for example, is an LGBTQ positive plus program that really understands and appreciates that people have different needs based on where they come from. And so we'll talk a little bit more about that. So let's talk about kind of the goals and objectives of this session. I'm going to start and give a backdrop about the history and the relevance really of ASAM and the placement criteria. Everybody may not have kind of the foundational understanding of really some of the field's evolution, and ASAM has been, you know, really the thread throughout much of the development that we have done. I'm going to then talk about the dimensions themselves and the levels of care themselves to really kind of define those things for you. So as I'm talking and Jim is talking later, you can really think and track about what does that mean. Jim is going to really give you some case examples from his work of how do you apply that in the real world. You know, so if I have a patient sitting in front of me, what do I talk to them about? What questions do I ask, and where do I go with that information? And then what I will close on is really talking about, from an organizational standpoint, that this isn't just about assessment, and it isn't just about placement. It's about the treatment continuum of care. And are you truly integrating the principles of the placement criteria in ASAM into the work that you do? So I'm going to talk through some of those details, and that's going to be a whole lot of fun. I'm excited about that. So I turned 50 a couple weeks ago, so I'm going to wear these glasses now. Apparently it's a requirement of being this age. So thinking about kind of the field as a whole, just as kind of a reminder that we can find evidence of people with substance use disorders really going back 10,000 years. In the United States in 1939 is when Alcoholics Anonymous was started, and in 1953 Narcotics Anonymous was started. And they were really bringing attention to the fact that there were substance use issues in this country, and people needed help. In 1954, ASAM started as a group, the American Society of Addiction Medicine. It was a group of physicians that wanted to really come together and come up with some best practice ways of treating people. And eventually, and it took them really until 1988 before they had a board certified addiction specialist. So I've been in the field since 1990. I don't really have a living memory of doctors that were not certified in addiction counseling. That's kind of how recent this is. But that was a big focus. So from the placement criteria standpoint, really the first swipe of this was the Cleveland criteria. And what the doctors and those that were using it understood was that we were treating patients and we didn't have a decision tree to say this patient belongs at this level of care because of these reasons. So they put together kind of the first swipe of that. The National Association of Addiction Treatment Providers really kind of came in because there was 40 to 50 different sets of criteria. It was very, very state specific, program specific. There was no continuity. And so NAATP then partnered with ASAM, and in 1991 published the very first version of the placement criteria. And what is really cool about ASAM, and I think our field in general, is that that wasn't a static delivery. They didn't say, okay, here it is, let's stay with it. That consecutively, as the years have gone by, they've evaluated what's happening in the environment, what substances are being used, what new medications are available, and updated the placement criteria as well as the treatment modalities really quite significantly. The piece that ASAM has done more recently, which I'm very excited about, I've been on 2 of the work groups that are really looking at the levels of care themselves to say, okay, if I provide level 3.5, residential substance use treatment, what does that mean? What is the criteria? What's the staffing? What are the protocols, et cetera? There is still no standard of that out there that is universally accepted. But ASAM took a first step. They put together a set of criteria and they partnered with CARF, the accreditation body, to certify locations. And so Gateway Foundation was one of the pilot sites that went through the certification for the first time. And now it's becoming more and more widespread. This is a huge contribution to the field. And I'll talk a little more about kind of the field evolution shortly. Another contribution that ASAM put out there that was really meaningful is if you look at groups like SAMHSA and NAATP and ASAM, we have a long legacy of really kind of leading the voice of addiction treatment in the United States. ASAM has one of the most respected voices, and they knew that there was not a shared definition for substance use that payers and legislators and providers could kind of look towards. And they put out what is in front of you. What I really like about this is they talk about, number one, it's treatable. And that's really a stigma reducing strategy to say it's treatable. They talk about how it's a chronic medical disease. We know now it's a medical disease. We can prove that it's a medical disease, but it's not universally thought of as a medical disease. There's still people that think it's a moral failing. They also really highlighted that it is a complex interaction between all the different factors that we'll talk about shortly in the 6 dimensions. And that the final piece of that is that this is a behavioral disorder. So it's a medical disease mixed with kind of a mental, emotional, spiritual disease that has a behavioral component. And so all of those need to go together. This was really kind of groundbreaking, and I was excited to see it. Something that has been really in partnership, and this may be old for everybody sitting here. So if this is something just kind of listen along. If it's new to you, I hope this is educational. But when I first got in the field, the Diagnostic Statistic Manual was how clinicians would make choices about really what was somebody's diagnosis. And the reason for the diagnoses was that the research combined and supported the diagnosis. So that if I was depressed with major depression, that there was research that said what's the right treatment for major depression. When I got in the field, the DSM-4 was the guiding book that we used. And at that point, it really defined substance use disorders as either abuse or dependence, not as a continuum, which really is more consistent with ASAM's way of thinking about substance use disorders. And frankly, it made clinically more sense. I remember sitting there with patients trying to make a decision. Is it abuse? Is it dependence? That wasn't a good fit. And so in the DSM-5, in the most recent edition, and I think the most recent edition was 2013, they really changed the paradigm. And they said, instead of this being an either or, let's make this a continuum. And so they identified 9 symptoms that really were carryovers from the others. But they said, let's break it into mild, moderate, and severe. If you have 2 to 3 or 4 to 6 or 7 to 9, that would really influence the severity of your symptoms. And as I share these, later you're going to reflect on this and understand kind of the partnership that they have between the ASAM principles and the DSM principles. And this is part of building this into your organization, is that if I know that I'm seeing a patient who has an opioid use disorder, severe, that most likely they have physical withdrawal symptoms, they probably have medical impact from their using, they probably have psychiatric symptoms as a result of their union. So this is really about the relationship between the two. And so that first group is really about impaired control. And this is taking it more than you intended to, spending a lot of time using it, having cravings and urges. In many ways, this is the compulsion that we talk about. The obsession and compulsion is a core component of this disease. They then, kind of the second category is really the social impairment. Is how is it impacting my work, my home, my school? Leah shared that I'm a person in long-term recovery. And what I believe recovery is really kind of the replacement of very maladaptive behaviors with very adaptive behaviors. And we can look at how am I living today? And how does that influence and indicate how I am doing? The next group is really kind of the risky use of substances, and this is, frequently it's drinking and driving is a good example. Being in physically dangerous situations is a good example, and continuing to use regardless. And then there's really that pharmacological criteria. And historically, if we look at the use of ASAM, and I think there's still people that think about this, it was kind of the withdrawal and the medical part of this that really decided, do they get detox or do they not get detox? And that paradigm has changed dramatically, which we'll talk about a little more in a minute. So if you think about the progression of addiction, really moving from non-problematic use to diagnostic use to really significant use, I put this on there really kind of as a reminder that as we think about levels of care, that it really works in concert with these kind of things. Is that in the beginning, I think people use substances because they work. They do something for the individual that they want done. Maybe it makes them feel less depressed, less anxious, less bored, less socially uncomfortable. Maybe it helps with trauma symptoms, whatever it is. When they start using it, it works. And it begins a process in the brain that becomes more and more reinforcing. And so they seek out that drug more and more, and it pushes out kind of the other stuff in one's life and gets to the point of no control. And that when we get to that point, that's really where the higher levels of treatment are so required. So if you remember one thing that we say today, and if you learn one thing about the ASAM placement criteria and really integrating it into your care, what I like about this is, in essence, it's really kind of two pieces. It's matching the severity of one's symptoms and the obstacles, to them being successful, and matching it to the intensity of service. And so really thinking about very carefully, if I'm a residential treatment provider, that doesn't mean every person needs residential treatment, for example. If I do outpatient, doesn't mean every person does outpatient. We need to be a placement triage unit, no matter what we do, to help people find the right level of care. And from a motivation standpoint for you as members of organizations, kind of the motivator or the challenge of this is, do you have an infrastructure that makes you capable and competent to successfully do this? So going a little deeper into that, the criteria background, in essence, is first, it's those guidelines for assessment, service, planning, placement, et cetera. It helps us decide where are they in the system. It's a framework. It's a way to think about assessment. Because if you think about the 6 dimensions I'll cover, it's really complicated. When I got in the field, we had a 1-pager that had the dimensions on the side and the severity on the top, and you circle the boxes. And you look at the sheet and say, okay, what do they seem like? What do they really need? We are so much more sophisticated now that it's actually made it more challenging. And then that level of care description that I talked about, and then finally, like helping us figure out from an algorithmic standpoint, how do we really use this? So if you're not as familiar with the dimensions themselves, these are the dimensions. Dimension 1, acute intoxication or withdrawal potential. This really is, as somebody walks into your door, really where is their brain and their body in relationship to the substances that they're using. We know that there's some substances like benzodiazepines and alcohol that the withdrawal can kill you. We know there's other substances like opioids and things like that make you kind of wish you were dead, but they're not going to kill you, but they drive big relapse potential. The second, about the biomedical conditions, this is really kind of thinking about 2 things. One is, what has been the influence of the substance use on the person's medical conditions? Do they have pancreatitis? Do they have kidney problems? Do they have hypertension? Other types of things that are related, or do they have underlying medical conditions that are making it difficult for them to be successful in treatment? We also look at the emotional behavioral part. There's patients that have had traumatic brain injuries, for example, people with intellectual disabilities. There's people with mood disorders, anxiety disorders, so forth, that we have to evaluate those things in order to successfully place that person. And so as I think about those 3, kind of areas, in essence, that's really the symptom presentation that we're experiencing. The second 3 are really around those obstacles and strengths that enable them to be successful. So how ready are they for change? Do they want treatment? And frankly, to me, that one is a lot more controversial, because I don't know I've ever met a volunteer for treatment. Something is forcing them in, even if it's themselves. That readiness to change is pretty hard to monitor. And I think part of our field's responsibility is, and I think this is some of motivational interviewing, is to engage that person and help develop readiness, frankly. The other is, what's the relapse potential? And there's a lot of factors that we can look at to evaluate relapse, and Jim will go into that a little bit. And then the final one, and this is really about that kind of continuum of care again, is what is the recovery environment that they're going to return to? Because if I have somebody who lives in a household with people that use substances, lives in a community where substances are everywhere, doesn't have work, doesn't have insurance, that person's recovery environment is so compromised that I need to think about, what do I do after the different levels of care, and how do I help them sustain longer term safe environment to be. And so then you have to think about what's the relationship between the dimensions and the assessment. And this is really where I think from an organizational standpoint and from a staff standpoint, we needed to think about what are the core competencies of our organization and our staff's ability to successfully assess. Because if we are not good at screening and we're not good at assessment, everything else is going to fail. Because really the development of the process is we screen the patient and assess them, determine what's the right level of care. We put them in that level of care and we treat them. And based on the assessment, we decide what are the goals we need to help that person to work on. And so this is very complex and really requires organizational, systemic focus. For the levels of care, if this is something you haven't been exposed to before, you can see that it's a continuum. Early intervention is the only one of these that's not considered treatment. This comes into play kind of in the DUI world. If I'm arrested drinking and driving, and I take my state-ordered, my assessment, and they find out I don't have a substance use diagnosable disorder, but I have problematic use, I might go into a 20-hour education curriculum like Prime for Life. But everything else from level 1 to 4, those 6 dimensions are really used to figure out where do they start. And it's really important for me to kind of emphasize that it's where they start, not where they end. Because if I came in, for example, and really partial hospitalization, 2.5 day treatment type environment was the right environment for me, I don't then graduate and not do anything else unless that's really what's indicated. That it probably means I want to step down into lower levels of care, have a longer term episode of care. The science is pretty clear that 12 months seems to be kind of the magic number in which somebody is really going to escalate the outcomes that they can experience. This also relates to the readiness for treatment. We've assessed a lot of people over the years that really require 3.5 level treatment, for example, but they're not ready for that. They don't want to do that. They feel like it would be too damaging to their life. And so we start them at a lower level of care. And I remember doing assessments with patients and kind of saying, why don't we try it here? If it's not successful, would you be willing to then talk about residential treatment? And so really it's that kind of back and forth, up and down. This is the last piece that I want to share before I hand it over to Jim. And this is one of the bigger contributions I think ASAM has also done more recently, is they're working specifically on withdrawal management protocols. So if we go back to this slide for a minute, historically, if you had withdrawal symptoms, like when I first got in the field, if you had withdrawal symptoms, period, for the most part, you were in 3.7 or above. You know, you were either in a medically monitored non-hospital detox or you were in a hospital detox. Today, we do ambulatory detox. So we have a lot of patients that are successfully able to come to outpatient treatment. They can get on medication-assisted, recovery, MAT. They could do different kinds of things that help them be successful. So no longer is the substance they're using or the withdrawal that they're experiencing the only indicator of level of care. And that's a really important one that I want you to take home with you, that what you heard shared in the beginning of this presentation is that's one area that's not as assessed as much. My theory about why it's not assessed as much is that some people see that as a rule out. If you have withdrawal, I'm sending you across the street for evaluation. So with that, I'm going to turn it to Jim for application and practice. Jim?
Thank you, Tom, and thank you everybody for allowing us to be here with you today. I'm excited to share some of the practical applications of the ASAM criteria and treatment, and hopefully provide some new information to all of you as you're working with clients who struggle with a substance use disorder. First and foremost, what's most important as we look at the different dimensions of ASAM and we're working with an individual who may be struggling with a substance use disorder is we want to make sure that we're looking at the problems, but in addition, equally looking at the strengths that a client brings to each dimension. And that's so important because, as Tom alluded to, we've known since the 1950s is when the American Medical Association first came out and said alcohol use disorder, it started with alcohol use disorder and progressed to substance use disorder overall, is a disease of the brain and a disease that can be treated. And so part of the assessment process when we're working with individuals is also providing them with education, because a lot of individuals coming in for the first time are still operating under the premise that this is a moral failing or a character flaw or something's wrong with them. Why can't they stop? Why is it so difficult to manage this disorder? And so starting out with education really helps us with not only providing a strength-based foundation to help clients share information with us so that we can make the right decision in terms of level of care, but also encouraging them to be open and honest and feeling comfortable doing that. So when we look at these dimensions, we have to equally look at what strengths does a client bring to each dimension, as well as what risk is associated with each dimension for them. And really, the ASAM dimensions become puzzle pieces of sorts. And as the puzzle starts to be put together, as we start to look at these pieces come together, a profile is created, or a picture of that person and their needs. And with the hope of looking at that picture from a clinical standpoint, how do we make decisions that really balance two things? And those two things are, and we've heard this before in other settings, not just in substance use disorder treatment, but this least restrictive environment idea. What is the least restrictive environment that this person could be successful in? And being able to balance that with the overall and overarching goal of wanting to have everyone, or as many people as possible, leave treatment with the best chance of sustaining and maintaining recovery. And so balancing those things are very challenging, as Tom said, and it's gotten more complex over time, not just in terms of how we view this disorder and understand this disorder because of the research, especially over the last several decades, but also because we want to make sure that this person has the best chance of success as we make treatment recommendations for them. If you can go to the next slide, Tom. There we go. And Tom talked a little bit about the DSM-5 diagnosis, and really this is something that is complementary and supportive of the ASAM dimensions. I mean, we know the science of substance use disorder. We know it's a disease of the brain, and disease education is an important component of treatment for individuals who struggle with this disorder, regardless of what level of care they end up in. And so really looking at it from this lens is important to us here at Gateway. You know, our tagline is addiction medicine saving lives. And we really want to make sure that as we're making a level of care recommendation, that both the individual and their families over the course of their treatment here, whether it be an outpatient or residential, become experts in the science of the disease, because we know that gives them the best chance of maintaining recovery as they move forward. And, you know, Tom talked about a lot of these, but as you look at the DSM-5 diagnosis, you can see why it really supports the underlying ASAM dimensions, especially around understanding relapse and risk and understanding biomedical conditions associated with the disorder, understanding that this is a disease of the brain. So I always say it gives the illusion of choice because it's behavioral, but really what we know from the science, not only from ASAM, but DSM, is a lot of these things that happen to someone who struggles with a substance use disorder that look behavioral really are outside their locus of control initially. And that's where both treatment and medication assisted treatment come into play. You can go to the next slide, Tom. So how do we look at all of this? You know, as clinicians, as counselors, we need to be able to organize the assessment data into a level care or placement decision, and really taking the dimensions and starting to put them into this puzzle so that we can create a profile and recommendations that will be in the individual's best interest. And that is challenging because, you know, there are, as we look at the dimensions shortly, you're going to see that in each dimension, there are things a counselor needs to be asking both the client as well as themselves in making decisions about risk and severity level and level of care and eventually placement. First and foremost is, why is the client here? You know, what are they looking for and what do they want right now? What we know that's so important when we're working with a client is we have a small window of time to help engage them in the treatment process. That one call or that assessment process, if we get them into the treatment center, is really going to be a make or break for them, and how we present that information to them, how we understand what they're looking for in making recommendations is going to be important, not necessarily in terms of us making a recommendation based on only what they want. There are some clients that may want a level of care that's not appropriate for them. I've had clients come in looking for outpatient that just won't be successful in outpatient. And, you know, giving them an opportunity to be an outpatient, might be okay for one client, but for another client may be such a setup for failure and put them at such risk that really helping them to understand the benefits of residential or detox if needed is really the responsibility of the counselor. So it's balancing what they want and why they're looking for it right now with what is going to be in their best interest. And that's sometimes hard to hear for some clients. Just like if we go to a doctor and a doctor says, hey, your blood pressure is high or your cholesterol levels are out of whack, and this is really what you need to do to adjust this, or we need to be looking at medication. That's hard to hear sometimes, especially if it results in major dietary changes or lifestyle changes that we have to implement. And it's the same thing with this disorder. You know, looking at it from that medical lens, we need to balance with the clients looking for, with helping them understand what they need and what might be in their best interest in terms of their recovery process. The other piece of this is we want to look at imminent risk. And, you know, Tom will talk a little bit later about some of our strategies and protocols in terms of assessing for that, in terms of suicide risk and some of the tools that we implement. But that's the most important piece right now, is that initial assessment. Is there any imminent risk or immediate dangers or needs that need to be addressed in any of the 6 dimensions as we're making a level of care recommendation? Because that's so important. When we talk about the dimensions, again, dimension 1, does the client need to be at the hospital in terms of detox risk because of risk of physical harm as a result of the substances coming out of their system? Are there mental health conditions that will put the client at risk for self-harm or harm to others that we need to assess and provide support for as part of the treatment process? So those immediate needs or imminent risks are really important to look at and prioritize initially. Of course, we want to conduct the multidimensional assessment, looking at both ASAM and DSM diagnoses. In that conversation, we really want to understand a couple of different things, one of which are protective factors. Going back to the strengths, what are the protective factors a client has that will help them in their recovery process in all the dimensions? In addition, what are static risk factors, things that can't be changed? For example, history of trauma or experiences that they have had that have put them at risk for relapse or continue to put them at risk for relapse, as well as dynamic factors, things that we can address. So untreated mental health conditions that maybe have been in a place where they've not been stable for some time, and through medications and therapy, we can help stabilize those so they're not self-medicating those conditions with their substance use, allowing their substance use disorder to continue to progress. We also want to look at dynamic factors in terms of recovery environment. When we talk about that dimension in a few minutes, how does that look? What does the client need? What's going to help them be in the best place when they leave formal treatment, whether it be residential or if they're an outpatient? Where are they going home to, and what does that home look like, and is it conducive to recovery? So as part of that multidimensional assessment, we're not only looking at diagnosis using the DSM and the dimensions, but we're looking at those risk factors as well as protective factors that a client has and presents with that can help them in the recovery process. And as we start to look at these, we also want to look at what are the services that the client will need to address dimensions that are more severe than others. So going back to what Tom said earlier, what dose or intensity of services is needed for each dimension? And when we look at this, especially in the outpatient level of care, we also have to look at the impact of not only that client's needs, but the impact that client has on the larger group. And so, you know, in outpatient, because group therapy is one of the primary modalities that is used, not the only modality, of course, individual and family involvement is part of the outpatient experience, but group is a big part of that experience as well. We also want to look at the impact of that client and their needs on the group process as we're making some decisions in terms of dose or intensity of services. And again, balancing least restrictive environment with the needs of the client and their success in the recovery process, and being able to assess that post-treatment. So as a client leaves treatment, are they successful? You know, at Gateway, that's really important to us to be able to measure their success as they leave a level of care in terms of that dose response experience. Did they receive the appropriate treatment they need to be successful in the recovery process? We recognize, of course, that relapse is part of the recovery process. However, that being said, we want to do everything we can to minimize that risk of relapse. So making sure that level of care reflects not only the client's needs, but their ability to be successful. So if Tom, we can go to the next slide. So these are some of the levels of care, just as a reminder. This probably, as Tom said earlier, for some of you is not new information, but we really want to look at, as we're making decisions about the dimensions, what level of care is going to be in the client's best interest. For example, detox or withdrawal management may be something that a client needs to go through as part of the residential experience here at Gateway. And we have the ability to do that, to provide medication-assisted treatment for withdrawal, to help them safely detox. But for others, detox may need to occur at a hospital because of their medical conditions and the complexity of those medical conditions and how they're compromised because of their substance use disorder. We want to make sure that if a client's in residential, that we're really assessing for that level of care and making a decision and really looking at whether or not they're able to manage their substance use disorder in the community versus in a setting where they can be removed from the community for a bit of time, so that they can not only address the medical conditions and physiological conditions associated with their substance use disorder, but the psychological conditions that put them at risk for relapse. And, again, comparing that to intensive outpatient services and what used to be called basic outpatient services now is primarily called outpatient. For those clients, we really want to make sure that if we're going to have them stay in the community and we're providing treatment to them, whether it be 9 hours a week or we're providing 6 hours a day, 5 days a week, which is our day program, or they're coming in just 3 hours a week because they're in aftercare or what we call basic outpatient, are their needs getting met in the 6 dimensions? And most importantly, what does the recovery environment look like? So Gateway is able to provide that recovery environment for people who need it, recovery homes, and being able to partner that with our outpatient program. So as we look at the dimensions, the levels of care and recommendations for these levels of care are just really important to our overall assessment process. Next slide, please, Tom. So let's take a look at Dimension 1. Dimension 1, as you heard, is acute intoxication and withdrawal. And, in this dimension, we're really looking at what risks are associated with current intoxication levels, what risk is associated with withdrawal symptoms, because we know that people may come in either an intoxication state or a withdrawal state. And is client medically safe in the environment they're in based on these above issues or concerns? And if the answer to that is no, then what are we going to do about it and what recommendations should we make? A great example of this is, here at Gateway, we have withdrawal management and detox protocols in place. So if I'm a 40-year-old male that comes in who's been drinking and has an alcohol use disorder, let's say severe alcohol use disorder, and I've been drinking pretty consistently over the last several years every day, yet when our nurses assess me, I have stable vitals. So they assess my vitals. We have 24-hour nursing here at our facility. So we're assessing a client's vitals. We're looking at their seizure history in terms of withdrawal experience. We're not only talking to the client, but collaterals to make sure as much as possible we can understand what withdrawal risk looks like for that client. And again, so if I have no history of seizures as an example, and my vitals are stable, but I've been drinking pretty consistently, Gateway is able to put in place a withdrawal management or detox protocol to help that client manage their withdrawal safely in our treatment programs. And we'll have nurses and doctors continue to monitor that. And in a situation like that, we might be more willing to have a client come in and start the withdrawal protocol with us, as opposed to if I'm a 40-year-old client and let's say I have a blood alcohol level of 0.28 and I have a history of seizures and I have underlying medical conditions that complicate my alcohol use disorder and my vitals are unstable and my blood pressure is off the charts. A client like that would be best served initially in the hospital for medical stabilization, with the goal of us bringing them back to the Gateway treatment residential or detox program as they medically stabilize, just to ensure their medical condition is addressed appropriately. So in Dimension 1, that's an example of how we might look at the treatment approach and determine what steps are necessary to help that client be successful. In Dimension 2, it's really important to address any additional medical conditions that need to occur. An example of that is, we had a client just recently here in Aurora that was already on a liver transplant list, and to complete residential treatment was necessary for them to stay on that liver transplant list for alcohol use disorder. And so they're already coming in medically compromised. And so as we work with that client, we need to determine in terms of level of care, for example, how severe is their alcohol use disorder? What medical treatment do they need during their time while we're helping them treat this alcohol use disorder? And for example, what if a client, for example, needs to go to dialysis multiple times a day and throughout the course of the week? We need to factor that into our decision-making in terms of outpatient versus residential, in addition to the severity of their substance use disorder and the risk associated with that. And so as we look at medical conditions, we really want to make sure that we're assessing those appropriately, and then we're utilizing our medical expertise at our sites to make determinations about how do we make sure if this client's in residential, we're able to treat comprehensively and completely any medical concerns that they might have. Dimension 3, you saw this, I think, in, Caroline initially alluded to this in her initial slides, but we know there is a strong relationship between mental health disorders, trauma disorders, and substance use disorders. And I think a lot of organizations do a pretty good job of identifying that. I think the important piece to recognize when we're making decisions about level of care in terms of mental health disorders is how severe that mental health disorder is. Has there been any period of recovery from that mental health disorder or trauma disorder? How in depth of questions as a treatment provider we ask to better understand that situation. Those are important components in making decisions about how the mental health disorder influences the substance use disorder and thus influences our level of care recommendation. A great example of this is trauma. We know that 80% of clients that come in with substance use disorders have a trauma trigger, that there's a strong correlation between substance use disorders and trauma experiences, which although can be a static risk factor, meaning they've happened and maybe in their past, they also could be ongoing. And so what we do at Gateway, and I'm proud of what we do in terms of being one of the only treatment providers for substance use disorder that have incorporated the ACEs, or Adverse Childhood Experiences questionnaire, into our assessment process, is we do a really thorough deep dive into not only trauma, but mental health disorders to make sure we thoroughly understand the client's experience and their needs. So if I have a client, for example, with a severe opiate use disorder that's at high risk for not only relapsing on opiates, but also has a severe depressive disorder or a mood disorder, my approach with that client and a level of care recommendation based on those needs would be very different than if the client had an opiate use disorder with a mild mental health condition or no mental health condition at all. And so looking at their safety in terms of mental health conditions, as well as looking at their severity and trauma history. And I know there's some questions popping up as we're talking that hopefully we'll get to, is really important to us here at Gateway. And we really want to be, when we talk about trauma, especially in this dimension, or going back to dimension 3, be trauma responsive versus trauma informed. Because we need to meet the client where they're at, and that's where dimension 4 comes into play. We recognize, for example, that there are some clients that have to be in treatment, and there are clients that want to be in treatment. And there are clients that have to be in treatment that also want to be in treatment. And it really is the clinician's responsibility not only to assess that accurately, but to make sure we move that client from pre-contemplation, which goes back to that motivational interviewing stages of change approach, to being able to recognize the need to address the problem, and then recognizing the need for skills to address that problem, and hopefully helping them move to a point where, recovery is possible. And again, when we look at dimension 4 and we're looking at level of care, this is an important dimension, because if you have a client, for example, that has a severe opiate use disorder and has had, I'll give you a great example. We had a client in treatment, severe opiate use disorder. We ended up recommending residential because they had 3 near-death overdoses on opiates that they were revived by Narcan in each situation, who basically said, I'm not like your other clients. I've learned my lesson, called his mom, wanted to come home. That's a challenging client in terms of recommending residential versus outpatient for. And so really recognizing the need for helping the client understand their illness and moving them towards a place where they're wanting to do something about it is important in deciding residential versus outpatient in terms of level of care. If we move to dimension 5, relapse risk, high risk situations, triggers. Do the client recognize those issues? Are they able to move forward in recognizing the relationship between triggers and high-risk situations and their risk of relapse? When we're making decisions about level of care, that's an important component. I had a gentleman at one point say to me, he was angry at our therapist, our admissions therapist, because he heard her say he can't go to Cubs games right now. And he was really upset and he wanted to talk to me. He's like, why is she telling me I can't go to a Cubs game? And what ended up transpiring is the admission counselor, because his client had a severe alcohol use disorder, and this client said, hey, I want to be an outpatient because it's Cubs season and I want to go see the games. This was before COVID, of course. And what she was saying to him is right now, because of the severity of his alcohol use disorder and what we know about the brain's ability to manage recovery and heal from an alcohol use disorder, that the Cubs game was going to be a high-risk situation for him because alcohol was everywhere. And it was going to be really challenging for him with the severe disorder he had to maintain recovery and be in the community right now, much less be at a Cubs game. So those kinds of conversations are really important when we look at that Dimension 5 risk. And of course, Dimension 6, which is so important, is are family members a strength or barrier to the client's recovery process? Is their recovery environment conducive to recovery, or is it going to put them at risk for relapse? And that not only helps us make determinations about whether or not a client should be considered for residential, depending on the other dimensions and the impact on those dimensions to Dimension 6, but also on whether or not the client's long-term recovery is going to be supported by the recovery environment and whether or not they need an alternative recovery environment. And that's where halfway houses, recovery homes, and alternative living arrangements is important to us here at Gateway to make sure we provide the client with the appropriate support system as they leave the treatment level, whether it be outpatient or residential. Next slide, please, Tom. So a couple things to wrap up. As we use the criteria again, Tom said this earlier, there is no perfect equation or no perfect profile that's going to result in an automatic, for this person, they're going to go in residential every time. For this person, they're going to be an outpatient every time. This substance equals residential. This substance equals outpatient. It is really a combination of those 6 dimensions and the severity level and where the person presents, both in terms of risk and strengths, that help us determine whether or not it is appropriate not only to recommend that level of care, but also to keep that client in that level of care. And so as you see in this slide, as we make decisions about retaining a client at a present level of care, we really want to be able to determine whether or not they're making progress. Relapse is a part of the recovery process. That doesn't necessarily equal change in level of care, but if there's enough relapse risk, then we want to look at whether or not a higher level of care is more appropriate. And if we go to the next slide, Tom, I think we'll see here that when it is appropriate to transfer or discharge a patient from the present level of care is really about 2 things. Have they achieved the goals? Have they maintained recovery? If so, then we're talking about discharge with them. That's different than they're unable to resolve the problems at that justified admission at that level of care. They may be still struggling with mental health conditions that are becoming unmanageable. They're having consistent relapses. They're putting themselves in high-risk situations over and over again that lead to relapse. And one of the things that's important in this determination is even though a patient may have not necessarily relapsed on the particular substance that they struggled with, they're not really practicing the recovery skills they need to maintain sobriety from that substance. So one of the things a clinician looks at is not only relapse risk, but is the patient utilizing the strengths and skills they're learning at that level of care to maintain recovery? And if the answer to that is no, as hard as it is for sometimes clients to hear, we really want to make recommendations to either a specialized program or a higher level of care to help them achieve and sustain that recovery goal. And I know Tom highlighted this a little bit earlier, but to wrap up, I really wanted to talk about a program that we're really proud of here at Aurora, and that's called the Recovery Advantage Program. And we established this a while ago specifically for individuals who struggle with alcohol use disorder. And one of the reasons we did this is, as we looked at the ASAM dimensions, what we recognized is that individuals who struggled with alcohol use disorder really had a unique and different profile than individuals who struggled with some of the other substances like an opiate use disorder standalone or a stimulant use disorder standalone. They tended to be, not always, but a lot of times more developed in terms, or more mature in terms of not only their age, but their, you know, life cycle and where they were at in terms of their struggles with alcohol use disorder. They needed more medical attention because, as Tom alluded to earlier, alcohol use disorder is one substance that you can die from in terms of withdrawal. And so we needed to manage that a lot more carefully in terms of the residential process. And we really needed to make sure we had a continuum of care that met the needs of that population. And so as a result of that, we've seen an improved not only completion rate in that specialized program for individuals who struggle with alcohol use disorder, but improved support and long-term sobriety and recovery in the community. So it's been an example of a program that's worked very well for us in terms of specialization. So I'll turn it back over to Tom now and let him kind of wrap up.
Awesome. Thank you so much, Jim. Great job. Real quick, Dennis Leary asked a question about asking for a little more clarity of the difference between really dimension 1 intoxication withdrawal versus relapse potential. And so the first is really at a high level, the intoxication a person presents with really is a decision tree for can you admit them to the environment that they walk into. And so really frequently this is about on an outpatient environment. If somebody shows up and they've been drinking, you really can't have them participate in outpatient therapy with other clients. It's not a safe kind of thing. If somebody presents and is blowing a 0.45, for example, and still talking and walking, that probably they need hospital level of care. So those are some of the decision trees about intoxication. With withdrawal management, that's really kind of what withdrawal medications do we use for a person, regardless of where they are in care. Relapse potential is about really kind of two things, but a lot of it is about discharge planning and ongoing treatment participation planning. And so we could get deeper into that if we have time, but I want to shift to one of the pieces that I get real excited about is we're kind of now shifting from clinician to leader. And what I'm going to talk about next, it's really about leadership. I coach kind of my organization, and I've tried to act this way in life. That every person in the organization is a leader regardless of role. So this doesn't mean you're a boss or not a boss, or you're a supervisor or a CEO or whatever. We all have a part in really driving a culture of excellence. So if I think about the Gateway Foundation, for example, our mission is to reduce the impact of substance use disorders and co-occurring mental illness by using efficient and effective care. So it's really kind of the what and the how. And so as I think about this presentation, ASAM placement level of care, it's that efficient, effective care component that is the most relevant. Is we as leaders of organizations, as participants of organizations, we need to try to decide what is an outside, scientifically supported, research-based, really kind of framework that we want to adopt in our organization. And what ASAM has been able to contribute, what NAATP helped to do back in the early 90s, really is a foundation that many of us can rest our work upon. And so our kind of evolution as a company is kind of a good example of how one evolves. And I'm going to talk the most about the last 5.5 years, which is how long that I've been part of this organization. But if you look at the field, we were first kind of a thought in 64, 65. We incorporated in 68 with our first residential treatment program. And it was for teens. Back then, the main treatment environment was therapeutic community model. It believed that you strip somebody down and then build them back up. You had like 2 years of treatment. That the world back then was so different that the ASAM placement criteria, it hadn't been developed, but even had it, most of the treatment was not caught up to that point. Part of why in the 80s and early 90s, the placement criteria came into place is that's when really psychiatry, medicine, counseling was coming in very, very strongly. So you look that we were one of the first in the country to do a co-occurring treatment unit. We were one of the first to do a gender-specific treatment. And those kind of things, again, really drove the conversation of who are we and what do we need to do? The period of 2008 to really 2012 was one of the biggest drivers, like from a time frame standpoint of this industry, in the sense that I was doing my doctoral work when Hillary Clinton and President Obama were running against each other. And they were all talking about healthcare reform. Obviously, you know, President Obama was the winner. And the Affordable Care Act, which went into place March 23rd, 2010, was where suddenly overnight, every single person with private insurance had substance use treatment benefits, which before it didn't. And I'll talk about that in a minute. But that was a game changer. So we as an kind of field have gone through this massive industry change. And so I want to talk quickly about kind of the change of the industry and the client themselves as it relates to ASAM. The payer reform environment has been one of those big things that prior to the Affordable Care Act, there was managed care. Some of the health insurance plans had substance use treatment, some didn't, but it wasn't really managed. It wasn't like what it is today, where you need an entire utilization review team. You need to create your systems to be able to argue effectively for continued stay and higher levels of care and all that kind of stuff. That reform process really brought into place a change in the way payers thought about treatment. And so part of our job as a program is, if we use the placement criteria, we need to effectively place them in that level of care and keep them in that level of care. And so this drove really a different dialogue than what we had before. And I'll talk a little more about that. One of the things around client acquisition and accountability that has changed is that consumers also are much more informed about treatment. They sit on the internet, they read about programs, they read about levels of care. You can go on WebMD, you can go anywhere and learn so much material. There's not yet, however, standardization universally. And there's not a clear measurement tool out there for a consumer to look and say, is this a good or not a good place? So Shatterproof, for example, is working really hard to try to create that. And they have that in some of the states now. NAATP, the National Association of Addiction Treatment Professionals, and I'll give a shout out, Dr. Annie Peters is on this call with us today, is really driving a values definition platform for the industry. That all these people are trying to say, what should treatment be? And if we know what treatment needs to be, we need to be accountable to that treatment. And that really forces this question of how do we then integrate it into the kind of environment of care? But at the same time, the people that we treat are becoming much, much more complex. Even in the last 5 to 10 years, they're more complex to where they were before. And I think one of those drivers has been the escalating increase of opioid use disorder and the co-occurring increase of overdose death that comes with opioid use. So in essence, the stakes are a lot higher. You know, I remember back in the 90s, it was like crack cocaine and alcohol were the two primary things that we saw in the late 80s. And that patient was really critical, but they were not in imminent risk of dying in the way that they are today. So it's really, really changed. And the medical comorbidity as a result has also changed. And if we look at the way that even that people engage in their environments and the way that they engage in treatment, and especially during COVID, technology has a place that we never even imagined before. In mid-February, Gateway Foundation, for example, we were treating about 1,500 people in outpatient treatment. It was all face-to-face. By March 15th, it was all virtual, every single bit of it. Like, think about what a massive systems change that is in 1 month's time. So if we don't fall back on the science and the structure that we have, we really become rudderless and we don't know where to go with it. And as Jim really did a great job talking about, is the psychiatric comorbidity of our patients is that much more dramatically significant as well. And if I treat somebody's substance use without their mental health, their likelihood of relapse goes up, and the same in the opposite standpoint. So it's really forcing us to consider, are we competent or are we not competent to deliver all 6 dimensions of care? So in thinking about organizational change, this is a model that I like. I think I actually stole this slide from Annie Peters. So Annie, this one is yours. It's a way to kind of think about how do you evaluate it. And so when I came into this organization in 2015, one of the first things that I did is I put together a team of subject matter experts, of leaders that included nurses, counselors, quality people, et cetera. And I said, give me a baseline analysis of the Gateway Foundation. Tell me what we have. Tell me where we're strong, where we're not strong. How are we evaluating outcomes? How are we dealing with mental health, substance use, et cetera? And that group really drove a massive project that I'll talk about in a minute. But in essence, they wanted to build a baseline of where we were as a product, as an environment. And with the ASAM placement criteria and with best practices, did we have them engaged or not? That group really worked to take what they found and turn it into action. That over the last 5 years, we've had an incredible run. And it's interesting doing this presentation. It gave me really a kind of increased appreciation for how much work the Gateway Foundation team has done. It's been remarkable. So as we figured out from that baseline study of what did need to change, is that we saw, for example, in dimension 1, that we did not effectively, throughout our system, have ways to deal with the withdrawal potential that patients had. So some people were undertreated, and if you undertreat withdrawal symptoms and somebody's in treatment, they're more likely to leave treatment, for example. We were also denying patients that we could have accepted. So we didn't have effective withdrawal management protocols. As far as dimension 2 with medical, we also didn't have 24-hour nursing everywhere. We didn't have a medical director who was a board certified addictionologist and psychiatrist. That we didn't have the medical staff competencies and strategies in place to really effectively address the person. From dimension 3 with that emotional piece, that we know 60–70% of people have a co-occurring disorder. We didn't have universal competency on how to deal with substance use and mental health symptoms. And that's a massive deficit. We also knew from a technology standpoint that we were on a very outdated electronic health record, an outdated financial platform. We had no values platform in order to really measure outcome data. There was all these technological problems. And we even identified that from a staffing standpoint, from compensation and benefits, that we were dramatically underpaying our people versus what we pay them. We found that 50% of our people were in the bottom quartile of compensation. And I'm happy to say today there's almost none, that we have shifted all of them. We've invested over $10 million into compensation and benefits, because if you don't have the right staff on board, that you cannot have the right knowledge base, you can't have engagement, all those kinds of things. We also realized that our footprint, our continuum of care, did not effectively embrace the 6 dimensions of care. We did not have 3.7 level detox. We didn't have outpatient treatment where everybody needed outpatient treatment. So there's been a really exciting project that's going on in the time that we've been here. So as you think about that baseline, those are all the problems. Those are all the opportunities that we found in order to improve our system. We then went through kind of this process of like, well, who needs to change in order for us to effectively address those deficits? How do we move from where we are to where we want to be? And it really starts with the team. So we looked at our leadership team and said, do we have the right leaders in the seats? Jim is one of those that was really a brilliant leader. He was, I mean, I say this when other people are listening, but you know, Jim is one of our strongest leaders. I love him. He's a fantastic leader. And he was one of those that we helped make a champion of change. And Jim really drove a lot of the stuff that we did in this organization. We brought on a new medical director who's a full-time dedicated person, and he did the work necessary to really update all of our dimension 1 and 2 work. We looked at the clinical teams to say, you know, do we have the right clinicians on board? Do we have the right financial staff who can bill? Do we have the right utilization review staff? And one of the things that we found, pardon me, one of the things we found in the intersection between clinical and utilization review is that the payers are really looking at medical symptoms right now, almost more than really kind of the other dimensions. Are they saying, are they medically necessary? They're defining medically necessary as the body, not as the mind, body, and spirit. And so we had to retrain our utilization review teams and kind of restructure them even. And even from development, if we wanted new sites, if we wanted new locations, if we wanted new services, do we have the staff in place that know how to make that happen? And we also wanted to change the consumer. And what I mean by that is really kind of 2 things. Is this is a very competitive business right now. And our business model, in essence, we treat people with commercial private insurance, with public insurance, and with no insurance. And we have a national network in correctional institutes. We wanted to diversify that portfolio of people that we serve more. And we wanted to serve more people that were currently underserved. And so these are some of the who changes that we need to make. So then if I'm going to change things, how do we actually do it? Well, I think that the first thing that really makes the difference between effective change and ineffective change is around culture. I could write tons of policies and procedures. I could buy new buildings and open them. I could hire new people. But if we don't effectively change the culture of the organization, all of it fails. If you haven't read John Kotter's work, he wrote this incredible book, I think it's Leading Through Change. You can look him up, sorry. And he wrote a really wonderful book called The Iceberg is Melting, which is an allegory of his stages of change. And I have used that as a guiding principle for myself as I think about how do I lead organizations, how do I lead change? And really the first step of change is kind of setting the urgency. Like, why does this matter? And we do staff engagement surveys of our people every year to understand what do they like, what do they not like, where are they engaged, where are they not engaged. And the mission for almost all of them is the strongest rated, highest functioning thing in this organization. And so to create urgency in helping profession organizations, it's really, I think, needs to be driven by the mission. Is, are you most effectively treating people? Are you giving them chances to be successful? Are you leveraging the science? And this created excitement. And the second stage of Kotter's work is really around building that coalition of people. And so some of the folks that I put on that baseline analysis group were the ones that we thought were going to really not want to change things. We also put people on there that we knew wanted to change things. And I don't know how many people work for Gateway are listening, so I might get in trouble right now. But like purposely, we wanted to put both sides of that on there because then they'll get buy-in. And it worked. That we have accomplished so many things over the last 5 years that it's really kind of exciting. Well, and one more thing of Kotter that I think is really important is what he feels like is one of the most important things is being able to understand your vision, develop your vision, and communicate your vision. And if you can't do that, people don't know what to get on board with. And that's really an exciting opportunity. So the sequencing of this process, just to kind of reflect on this before I talk about some really the deeper details about what we were able to accomplish, is you've heard me talk about that baseline. You know, what is the current status? You've heard me talk a little bit about the response, you know, of building a strategic plan that really will accomplish those things. And strategic plans are challenging to write, especially when they're really complex. And so one of the things that we did is we really bucketed strategic planning into different areas. So one of the examples I'll talk to you about in a second was around dealing with mental health comorbidities. That was one entire project that we had a dedicated project team to, with a dedicated vision, dedicated resources. We invested over $1 million into creating that competency in that program. And that leads to then training and implementation and then reassessment. And perhaps the most important piece of any sequencing is when you finish a reassessment, you go back to the baseline because that's your new baseline. And it's really that constant feedback loop of quality improvement. All right, so let me talk to you about, I want to make sure that we have some time for questions, if we have some. So as it applies to ASAM, let me kind of talk first about withdrawal management and dimensions 1 and 2. So I shared with you that we brought in Dr. Ruin Rafian, and Ruin kind of did an analysis specific to withdrawal management protocols in the organization. And we found that we did not really have consistent protocols. And we had some medical directors at one site that their comfort level was here, another was here, another one was up here. And really he standardized. And he trained the prescribers to understand what to do. Historically, there were a lot of people that would be discharged or denied from one site where another site would admit them. We wanted a standardized level of care throughout the whole system. So that was part of bringing in 24-hour care. It was part of rolling out withdrawal management. We had MAT in some sites, but not others. So we rolled out MAT to all the sites. And so you think about just that one intervention, and you go back to the ASAM placement criteria. Suddenly you can take more people than you used to take, but you also can better treat the people that are in your organization. And that was a massive accomplishment for us. Like, I'm really excited about that. The other piece around the continuum of care is we realized first that we did not personally provide 3.7 level non-hospital medical detox. And we were able to treat people in 3.5 that had pretty acute withdrawal symptoms, but in some ways it was influenced by where the facility was. So Jim's location, for example, you literally walk across the parking lot and there's a hospital. So kind of the comfort level of a high-risk patient, it's like 60 seconds to get them over to the emergency department. Whereas we have other ones that it's 20, 25 minutes. And knowing that difference of environmental situations, you need to have embedded in the site the medical resources and the medical protocols to deal with that population. So we're in the stage right now, and by June, we'll have 3.7 level of care in all of our programs. And that is a business opportunity, it's a mission opportunity, and it's a best practice opportunity. And it's really exciting to me. Another one, going to kind of the mental illness part, you know, ASAM has a really lock, I think, on understanding placement. They don't have a lock on some of the related things like mental health and substance use treatment. So we looked for a benchmark, and Dartmouth University certifies programs using a DDCAP model of really, if you say you do dual diagnosis treatment, are you actually competent to do dual diagnosis treatment? And this again gets back to dimension 3, that emotional, psychological piece. One of our sites was one of 2 units in the country that was certified with DDCAP Enhanced, the highest level. And so we did an analysis of the rest of our organization. We had a work group that kind of identified this, and each site built a development plan to say, we're here, we're here, and we're here, and now have all of them meeting the enhanced level. And that was a big financial investment. But what I know is now the outcomes of those who come into our treatments are better, and that's fantastic. So the last thing I want to talk about in relation to this, and I could talk all day about the modifications and improvements that we have done, but the last one that's really critical is really around your technology and your infrastructure and how you document and communicate people's multidimensional functioning. So their strengths, their obstacles, their symptom presentation, their diagnostic presentation. And our old electronic health record wasn't capable of doing it in a unified manner. So we did an RFP process, and we selected NetSmart's product, My Avatar, and invested almost $5 million in taking that product, personalizing it, and making it, you know, electronic health records are tough everywhere. I don't know if I should say that online. There's not like the most beautifully perfect thing out there in the world. They all have challenges, but we made this product what I think is the best on the market for us. And what's powerful about it is that the screening process feeds to the assessment process. The assessment is truly a multidimensional assessment that pulls from all the principles of ASAM. And that then helps the clinician to make treatment recommendations, what level of care and what goals should they work on. And part of the strength of a product like that is you're going to have clinicians at different levels of their career with different levels of competency and comfort in dealing with substance use patients and placement of substance use patients. And this really prepared us to do that. And we also launched a new financial platform so that we could effectively bill more effectively. So the last thing that I want to share, and this is, you know, something that I think I've dedicated much of my career to, frankly, is if we're going to provide care and we don't know if it works, then we can't improve our product, and we can't, frankly, stand behind our product. And one of the things that the work group did in the very beginning is I asked them to look at how do you measure outcomes. And what they shared with me is that we got client satisfaction scores. We didn't get outcome scores. And we were only doing client satisfaction scores from successful graduates. So think of how many people you're missing. 30% or so of people leave earlier than they're kind of supposed to. So we, in essence, had a cherry-picked population telling us what they liked and didn't like, but we didn't know if they were able to continue their abstinence, improve their quality of life, et cetera. And so the first thing we did is we hired Omni Institute out of Colorado, and we did a 12-month prospective study where we had a random sample of patients. Aurora was one of the sites. Our Lake Villa site in Illinois was a second site. And we tracked those patients for a year. And we looked at all of the things that matter. And we got some great learnings out of that experience. It was a really powerful thing. We were then able to take that and wrap that back into our product, wrap that back into our assessment, wrap it back into the places that we treat people. But it was like 150 grand to do this tiny little study. And we knew that in Illinois, for example, we graduated 15,000+ people last year. We can't do that type of environment. So we built into My Avatar, into the electronic health record, the brief addiction monitor that we use for patients when they walk in the door and at specific discrete periods during their treatment. But we also want to know what happens after treatment. And so we built a phone application, a digital thing that I actually have on my phone, where we can send that brief addiction monitor out to the patient at points past treatment. We now have 800 people that have downloaded that app, are active in that app, and it's a recovery environment. It's a kind of social support environment, kind of like Facebook for graduates of Gateway Foundation. So it gets to that relapse, it gets to a recovery environment because it's literally a technological virtual recovery environment. And we are now building the data to really understand where we are long term. So I think how I want to close is that we are looking at the next 5 years of what I think will be really continued rapid escalation of defining levels of care, defining quality indicators and value indicators, and you need to be at the table. And if you're not at the table, it's going to happen without you, and you may not like it. But I also challenge everybody who's on this call, if you took the time to be on here, then you care, frankly, about your own development and that of the organization that you work for. So take what we did, think of one thing, maybe two things if you're lucky, that tomorrow you can share with your coworkers, that you can challenge yourself to do for the rest of the week. And thanks again, I really appreciate it to the Shatterproof team. I will now stop sharing my screen and turn it back to you all.
Perfect. Thank you so much, Dr. Britton. I think we have quite a few questions here. I'm just going to go over, we have 8 minutes left. So if you have questions that you haven't put in the chat, please go ahead and enter those in. If we don't get to all the questions today, we'll be happy to have Mr. Scarpace and Dr. Britton answer those, and then we can follow up with you via email. Just before we get to the questions, I want to remind everyone that their next event will be in December. So keep an eye out for that email along with the survey for this event. And then we will also have a separate survey that we'd like you to take related to the Atlas portals. If you're a provider who is logged into your portal to look at Atlas data, then please participate in that. It should be a brief survey. So with that, let's go ahead and go to the first question, which is from Helen Vanderlen. When assessing with ACE screen, how do you respond to the responses in a shorter level of care, detox or IP? Thinking in more detail, a tenet of trauma conscious care is choice/empowerment, but generally in IP detox levels of care, the program is very structured with somewhat rigid expectations.
Jim, I'll turn that one to you.
I can take that. So it's challenging in shorter levels of care. What's important with the ACE questions is really to establish a baseline first and foremost for the treatment team or the counselor working with that client to understand the severity of risk this client has historically in terms of adverse childhood experiences or trauma history. And secondly, during the time you're with that client, to help them understand the relationship between those trauma experiences and substance use disorder and risk of relapse, and establish a foundation that really just starts in the detox level of care and hopefully through education with the client continues with either an individual therapist in the community, or if they're stepping down the residential, continues with that counselor in the residential program. One of the things we do at Gateway is we use that questionnaire in the admissions process, and then we hand it over or hand it off to the residential counselor, who then takes that information from the assessment and says, okay, I know you met with Nicole, our admissions coordinator, and you guys talked a little bit about this relationship between your trauma experiences and trauma history and your struggles with substance use disorder. Let's build on those conversations and establish this as part of your treatment plan as we're working together in residential. So that's just an example of how it carries over and continues.
Great, thank you so much. Another question from Helen. Thinking about readiness for change, what research exists in regards to approaches or skills that have a demonstrable impact on engagement? And what outcome measures do you use at your various levels of care? Thank you for that question, Helen.
So, if you're okay, Tom, I'll just take this one. So, I talked about this a little bit when I was, speaking about the slides, motivational interviewing, and really being able to use the motivational interviewing skills like open-ended questions and reflection and complex reflection, and some of the motivational interviewing tenets in terms of not only helping a client move through those stages of change, but what we do at Gateway is we assess all our counselors twice a year on those skill sets. So we're looking for as MI adherence or adherence to the MI model. And so we have all the counselors that have direct client care do a tape session with the client, and the supervisors who are, trained in MI and do the trainings for the sites and the staff will listen to those tapes and score a counselor and then give them feedback in an individual session. And we do that twice a year for all our counselors across the community division, because we really want them to become experts in that, not only in motivational and interviewing, but we know it's our responsibility to move the client through those stages of change as much as we can.
Great, thank you so much, Jim. So the next question is from Milani Wilson. Just to note, we understand the need for a continuum of care for SUD and mental health diagnosis patients. Unfortunately, we see that insurance companies often dictate the time a patient is covered in treatment, prematurely forcing them into a lower level of care, regardless of ASAM criteria, to the detriment of the patient. Is anyone else experiencing this frustration with Medicaid MCOs? And if so, how do you combat this?
Great, and I'll take that one, Jim. I think that is without question shared. I've never talked to another leader that doesn't experience that challenge. I think there's two pieces of feedback that I would give around that. One is that we've done extensive training to our clinicians on how do you effectively document care so that we have a good argument for continued stay. We also built into our system really effective ways to prove that they need certain levels of care. From a legal standpoint, we have lawyers we work with that fight for parity and parity enforcement. UBH versus WIT was a case out in California. There was really a kind of case-setting precedent that gives us a lot of teeth. But at the end of the day, there's only so much power when it is you on the phone with somebody from the payer. And so I think that the other piece of this is really how in our current reality do we provide the best level of care in the best environment during the time that we have with the patient? Because I'd love to have somebody for 60 days, 120 days, 6 months, 9 months, 12 months, or whatever. But it's kind of, there's a saying in Narcotics Anonymous that I've always liked, which is it's easier to change my perception of reality than reality itself. I think that's a guide for us in some ways, but that's a tough one.
The only piece I would add to what Tom said is, one of the things we did at Gateway several years ago is we have QI analysts and a QI director, and we look very deeply and closely at the record. And someone mentioned this in the comments, but you really need to pull your treatment team together and look at the weaknesses in documentation, because when we look at insurance research, that tends to be the biggest issue with denials is the record doesn't reflect all the great work that's being done at the centers. And so we, use that monthly QI meeting to look at the records in depth and make changes where changes need to be made to improve our success with insurance.
Great, thank you. We actually just have 1 minute left. I think looking at the chat here, a lot of the questions were answered in the chat. But if we would like to take one more question before we wrap up, if anyone has something that was not addressed. Otherwise, we'll be happy to answer questions via email.
Leah, I believe that there's one unanswered question from Trevor Payne in the chat, who asked, how has the current demands for organizations to address social justice and racial injustice affected how your organizations do business, if at all?
Wow. That is definitely a big question with 30 seconds left.
Yeah, no pressure.
I think that it's really important for all of us to embrace that we're living in a time where social justice is more of a conversation piece than it's ever been, but it is not more significant than it's been. And so we as an organization, for example, have really invested our time and energy for many years in creating an environment that focuses on diversity and inclusion. And it's really more about cultural competence, which was the language that I got trained on back in the 90s, that it is around how do you have a diverse workforce and how do you have an inclusive workforce? I heard somebody say recently that there's a difference between getting invited to the dance and actually dancing. And so one of the initiatives Gateway is about to actually launch in the next few weeks is one of my senior vice presidents as a representative of a diverse group and has really spearheaded a new project that we're going to do, a multi-year strategy of really improving our organization's foundation. I will take full ownership that we are not where we could be. And it's important for me as a white man to know that I can't fully appreciate or understand what other people's experience is, and therefore I need to build a diverse and inclusive team that can represent that with me as a partner. Thank you for that question.
Thank you. I can't think of a better question to wrap up with. So just to remind everyone that we have recorded the session. We'll make both the slides and the recording available to you in the coming days. Again, it will come with that survey. So thank you so much, Dr. Britton, Mr. Scarpace, all of you for attending. Please keep an eye out for a follow-up email, and I hope that you will all join us for our December 10th event, which will focus on patient experience. I hope everyone has a great rest of the day.
Thank you.
Have a great day, everybody.
Thank you.